Assalamu alaikum. So in this lecture we are going to discuss about principles of physiotherapy care for musculoskeletal disorders. In this specific lecture I will be focusing on non-traumatic disorders and pain, um, because for trauma we have different sort of principles which we will be discussing when we will discuss about fractures. Today, the focus is only and only on a non-traumatic musculoskeletal disorders and pain like knee osteoarthritis, shoulder instability, back pain, sciatica, etc. So the focus for this specific lecture will only and only be for non-traumatic pains and non-traumatic disorders. So the first principle is that the physiotherapy care should be patient-centered. Uh, this basically means that uh, our goals, our treatment goals, our clinical reasoning, our decision making, right, our choice of treatment, our problem list, everything should involve patient. So we should set goals in discussion with the patient. So our patient is uh, the center of our care. Say, if I can explain it further, you can think of like uh, patient education, patient informed care, right? So like we give patients the options, we assess and we educate and we tell them, see, this is what I think is going to help you. If he agrees, then we go ahead. So it's like hand in hand with the patient. So this care usually in includes context of the patient. We use effective communication and there's a shared decision making, as I told, right? So I may tell my patient, right, that walking is good for you. Do you like walking? He says, no, I don't like walking. So what do you enjoy? So he says, I enjoy cycling. So I say, okay, let's switch over to cycling. So the basic idea is that we do not give the same treatment to everyone. Our treatment, our goals, our problem list should be according to the individual, the human we are treating. It should not be focused on, okay, a protocol, right? So, for example, knee osteoarthritis. So, I will give the same exercises to every patient. That should not be there. Ideally, it should be based on his impairment, or his problems, his pain, uh, his uh, his coping skills. So all those things. So I hope uh, this makes it clear, right? So whenever you are trying to design a treatment, your patient should be involved in the decision making, and you should be effectively communicating everything with him, and it should be individualized care. It should not be a generalized care. Next principle is um, that when we are assessing our clients or our patients, we screen them for having serious pathologies and red flag conditions. So when we are taking history from the patient, we make sure that we identify anything in the history that suggests that the patient is having a red flag or the patient is having a serious pathology. For example, our patient comes with back pain and he says during the history, and when we are asking him, he says he doesn't have bladder and bowel control. This means that the disc herniation or the compression of the spinal cord is going on. It's a serious pathology. It's a red flag. Maybe a cardiac equina which may require surgery. So this may need a referral. So we always make sure that when we are seeing MSK pain, we make sure that it is non-serious, and that means it doesn't require further referral and it doesn't have any red flags attached to it. So if red flag, as the name suggests, red means you need to stop, you need a referral, you need a further consultation with another specialist. So make sure when you're assessing uh, the patient, when you're listening to his story, that you identify key factors, key points from the history, keywords from the history which may suggest that there's underlying serious pathology, like fracture or dislocation, subluxation, which needs further care, further investigation, further referral, or there is a sign of red flags like maybe cancer, non-musculoskeletal pains, so which again needs further investigation and evaluation. See, this principle is very important because it prevents any harm to the patient, right? We make sure that we are treating efficiently and we are not treating something which is not under our scope. So if we are treating something which is not under our scope, like, things may go bad to worse. So this principle is very, very important whenever you take history. Okay, please remember to look for serious pathology and red flags. Not just in history, when you're sometimes the points are missed in history, but when you are examining the patient, you think like, oh, this doesn't look like a usual back pain patient. This is something else. The pain is coming from somewhere else. You're sure that, oh, this is not related to the lumbar spine. So whenever you're assessing, taking history, taking examination, make sure that you tick the points of yellow flags, red flags, and serious pathology. Right? These things needs to be referred. These things needs to be taken care of. The next principle is assessing psychosocial factors. Now, research has time and time again proven that we should view our patients' pain in terms of biopsychosocial model. That basically means that pain is not only generated by your uh, biological factors, right? So we know that, right? There might be a muscle um, dysfunction or injury to the tissue, right? So we know that there is some form of biological factors, but pain is an experience. It's right. It's not a sensation. It's an experience felt by the patient. So how does patient presents and explains pain will also depends on his psychological factors, social factors. Some patients have very good pain coping skills, so they may say the pain is very less, or they don't even report the pain, right? So, whenever you are again assessing, whenever you're trying to plan your goals for your treatment, please make sure that you take into consideration all the factors, right? So here you can see some examples in social factors, right? So low job satisfaction, environmental factors. So I have knee pain and my house doesn't have a lift and I have to go 4 floors climbing the stairs. That's a social factor that will aggravate my pain, will make it worse. Similarly, psychological factors, right? So I have a very bad experience with my knee pain consultation. So I believe doctors are not going to help. Modern medicine is not going to help. Okay, and then biological factors, right? There's a PFPS in my knee, patellofemoral pain, right? There's something going on inside the joint, tissue alteration which needs to be taken care of. So look at the whole picture. Don't just look at one thing. They are intercombined. You cannot assess them separately because we are treating a human, right? We cannot disassemble him and see psychological differently and social differently. Everything comes together. So the assessment should take care of biological factors which you are already assessing through so performer. And psychosocial factors, you can look for red flags, yellow flags, black flags, orange flags, so all those things. And sometimes the interesting thing is when we assess our patient, sometimes you will see that pain is more related with the psychological issues and may need a referral to a psychologist. So if we assess psychosocial factors, again, we will not miss anything. Okay, we will not do any harm to the patient. We'll make sure that everything is taken care of and we understand the pain in our best capacity. Next thing we need to take care is to make sure that educate our patients and educate ourselves that radiology is imaging is discouraged. So we do not need to send every patient for X-rays and MRIs and CT scans. Unfortunately, that is the practice which is going on, but that is against the current evidence. So research has again shown that what we see on imaging is not correlated with the pain intensity. So, and it has also shown that in some people, the defects shown on MRI and X-rays and CT scans are asymptomatic. So I may get a scan of my shoulder, there might be an inside injury or defect, right, which may be identified, but I'm asymptomatic. That basically means that not what not all the things which we see on MRIs and scans are significant. We need to make sure that we clinically correlate the findings on the imaging with the clinical signs and symptoms of the patient. Okay, imaging will never, as commonly said, right, we cannot see pain on an X-ray, right? Pain is told by the patient. So he may have a defect in the imaging, but he may be asymptomatic. He may have a defect on the imaging and he may be symptomatic. So it all depends on the clinical correlation, clinical reasoning. Unless it is indicated, radiology should not be encouraged. So in continuation with the previous slide, um, where I said it is discouraged, but that doesn't mean it should not be used. It should be used when it is indicated. So these are the 3 points where a physio or a doctor should think of uh, when to send the patient for the scans. If you're suspecting a serious pathology, so you're suspecting there's a cancer, you're suspecting there's a quadric quine syndrome going on, you're suspecting there's a displaced fracture, there's a dislocation, that means imaging will help, right? We are suspecting something which is serious. So this is the first point. Second thing is there has been an unsatisfactory response to conservative care. So for example, the patient was referred for physiotherapy. I started treatment and it's been 2 to 3 weeks. There is no improvement in the pain of the patient. That means uh, we are not going in the right direction. So in this case, imaging may give us a right direction. Okay, or we were seeing patient was improving completely, getting better. So for example, we are seeing a shoulder pain patient, and we were treating for 1 to 2 weeks. Everything was going smoothly, he was progressing, and pain was improving. But now all of a sudden he came to the clinic and he says everything has gone bad. His pain has provoked, his sign and symptoms have gone bad to worse, and we could not understand why it has happened. So we asked them and we don't know. So in this sense, again, in this context, again, the pain can be better, or the problem can be better evaluated using an imaging. Last but not the least is when you think that it will change your management. For example, uh, uh, ankle sprain. So you think, okay, this is a complete rupture, or there might be associated bone issue or bone injury, and it will impact my management. So let's get an X-ray done. So these are the 3 things which uh, where we can refer for imaging and where imaging is required. Unless and until these 3 things are present, radiological imaging should be discouraged. Next principle is that we should undertake a physical examination, which should include neurological screening, mobility, or muscle strength. So this we have discussed, right, um, many times, that our patients require a thorough assessment, okay, thorough subjective, objective assessment. And based on that assessment, we should be doing a clinical reasoning, identifying the differential diagnosis, ruling out the diagnosis, and ruling in the diagnosis. So our physical examination, right, should always be very thorough. It should cover each and every aspect of the patient's problem. Okay, and if required, we should always be doing a neurological screening like cranial nerve testing, reflexes, sensory assessments. Okay, and if not indicated, we will definitely be doing our common musculoskeletal assessments like mobility, strength, range of motion, okay, palpations and all those things. So once we have the history, based on the history, we will conduct a physical examination. So if the history says neurological testing is needed, we will do it. If it says not needed, we will do a comprehensive assessment of the musculoskeletal structures in and around the joint or in and around the problematic area. And during the diagnosis, during the assessment procedure, right, we should always be using outcome measures. We should always be using outcome measures to identify our patient's progress. Um, like for example, we can take multiple examples, right? So we are seeing um, a knee osteoarthritis patient who complains of knee pain for a past 1 week. Uh, we assess him. We do a thorough assessment. Uh, we do his complete mobility and strength assessments. Along with that, we also assess uh, his function uh, through outcome measures. So we can use a patient-specific functional scale to identify what functions are affected. We can use a WOMAC, Western Ontario McMaster scale, to assess the impact of the disease on the individual's life. We can also use quality of life scales. So we can use different sorts of outcome measures, and then we should give treatment, and then over a period of time, right, so after 2 weeks, 3 weeks, we should reassess these outcome measures, so see where the patient is moving. So we can reassess and ask, okay, you what's the functional status now, what activities you can do now, okay, what's the quality of life now. So we can use different sorts of outcome measures, patient reported, therapist reported, okay. Different forms of outcome measures can be used, and through these outcome measures we can get an idea uh, of basically what is happening with the patient, right? What the disease is, how the disease is impacting the patient's life. So always and always make sure that you use a validated, reliable outcome measure to assess the progress of your patients. Okay, and last but not the least, your outcome measure should be patient uh, specific, or it should be specific to the problem and the context. So make sure you are using a valid, reliable, and specific outcome. Okay, next principle is provide patients with education, information about the condition and management options. So patient education is the most important part of the management, right? So no matter what the condition is, no matter what the situation is, if you're not providing patient education, right, you're not going to get good results with your treatment. Your patients should be advised with what to do, what not to do, how can you help, okay. Uh, Not just that, it should also include about his prognosis, his diagnosis, about his condition. So you should educate him about every aspects of the care which you are going to give. So you can tell him, okay, this is the treatment I'm going to give, these are the things you need to do, these are the things you do not need to do, this is the prognosis, you will get better in 6 weeks. So we'll work out how to progress. So educate, effectively communicate as much as possible to the patient what you're going to do and what is going to happen. This will reduce patient's anxiety. This will improve patient's therapeutic alliance with you, right? You will develop a good rapport with the patient, and the patient will be more adhered and more compliant with your exercise program. So you may give exercise at home, he will definitely do it because he know the importance of the exercises, the importance of the treatment that is going on. Unless and until the patient is educated, it's very difficult for a physio to make sure that he does the exercises. So always and always make him understand why are you prescribing some exercises and what is going to happen and how those exercises are going to help. So patient education is the first um, pillar of physiotherapy management. Okay, the next principle is that manual therapy should be used as an adjunct to other evidence-based treatments. So that basically means that manual therapy should not be used as a standalone treatment. Manual therapy should be combined with other treatments like exercises, electrotherapy. It should not be the only thing that you're giving to the patient, because research has again shown that manual therapy alone is not effective in reducing patients' pain and discomfort. It is a very good tool when used appropriately and adequately. It is a very bad tool when used excessively and inappropriately. So please remember, it can do wonders, but it can also do harm to the patient when not used adequately. So whatever manual therapy you want to use, maybe soft tissue, joint based, it has to be combined with an exercise. The second thing you need to remember is the effect of manual therapy is very, very short lived. So the patient, when you give, the patient may say the pain is better. Half an hour, 1 hour down the line, the pain comes back. So if you want to make sure that the results of the manual therapy stays for a longer duration, you need to supplement it with other exercise-based treatments. So you may give a mobilization of the shoulder, but you also give stretching, you also give strengthening, you also give mobility. So that means that it is a package. So it should always and always be combined with other interventions, right? So the other thing to remember is basically um, not to use when it is not indicated. So not just so you may think, okay, this patient needs exercises, but just for the sake of manual therapy, you are adding it. That should also not be there. So if it is not indicated, it doesn't need to be combined. It only needs to be combined when it is indicated and it is required for the patient. Don't use it when it is not indicated. So this is the most important principle in the current scenario. Uh, when we see our patients uh, with non-traumatic musculoskeletal pain, they should always be offered non-surgical care before surgical care, right? That basically means anyone who is suffering from any sort of musculoskeletal, non-traumatic musculoskeletal pain should be offered physiotherapy or other forms of conservative care before opting surgery. Unfortunately, in the current scenario, in the current context, in most part of the world, surgery is used first, right? So back pain patient comes and just on the basis of the MRI, surgery is offered. That is non-evidence based. That should not be done. If we can help a patient without surgery, that's the best thing that we can do for them. So make sure when you're seeing your patients, you educate them that see these are the options. This is the non-conservative. This is the non-surgical option. This is the surgical option. You should try non-surgical option first, and if it doesn't work out, you can definitely look for the surgical option. Surgery should be the last option for majority of the non-traumatic musculoskeletal pain, as written on the slide, unless specifically indicated. So in some patients, surgery is indicated first. So first line of treatment. So in that cases, it's okay. So there's a serious pathology. It is very clear and evident that the non-surgical care, the physiotherapy is not going to help. Definitely, the patient can go for surgery. But if he has the option, if we can give him the option, we should ideally give him the option of non-surgical care. So this point will only be implemented if we work as a team. Uh, the surgeons needs to understand that it's not always uh, surgery is not always the option. Sometimes non-surgical care can also be a very good option for the patient. It can be a very cost-effective option for the patient. So only way to implement this point principle is to educate the patients and talk to our other members of the team, right? We need to talk to them that, sir, this is evidence-based for knee osteoarthritis. Before we can go for TCare, we can try for 6 weeks of physiotherapy care. If the patient improves, we may delay the TCare, but it should not be given as the first, as I've said again and again, right? It shouldn't Surgery should not be the first line of treatment unless indicated, unless there is a red flag or a serious pathology present. Okay, last but not the least, the last principle is to facilitate continuation or resumption of work. So we are a part of rehabilitation team. Rehabilitation basically means to rehab patient back to his uh, work site, okay, or his work. So always and always make sure that your treatment is facilitating that process. So if it is a sports player, make sure that he return to sports. If it's a uh, farmer, make sure he goes back to farming. So whatever is his work, we should make sure that our treatments, right, we use all these principles and facilitate his recovery to resume his work, make him a productive member of the society. We should not just give care for the sake of uh, reducing pain. Our whole goal is larger than that. We should make him go back to his optimum level of functioning as he was before, or at least to the level where he can enjoy his life and live a very healthy and life which is full of uh, enjoyment, right? So make sure that he has a good quality of life and he resumes his work. We don't only focus on pain, we focus on other aspects of, as we have discussed through the principles, you would have understood that we focus on many other aspects of the patient's care, the psychosocial aspect, right? The non-surgical care. So we have discussed so many principles. So we need to sit down with the patient, talk to him, educate him, tell him about the options, and then discuss out that okay, this is what we are planning, this is the goal, this is the outcome of our physiotherapy treatment, and hopefully when you do that, uh, you will be able to help most of your patients. Okay, so this is the reference I've used from where I took these principles. This is a review published in British Journal of Sports Medicine by the title "What Does Best Practice Care for Musculoskeletal Pain Look Like?" So in this paper, what they did is to look at different sorts of studies, and then they finally came up with recommendations. So these are recommendations for best care. Okay, I call them principles because they must be used, and if they are used as a sole, um, it makes life easy for the patient, it makes life easy for the physiotherapist, and it makes life easy for the whole team. Okay, you can go through this paper. This is open access, available on the British Journal of Sports Medicine. Just put, or you can just search it out on PubMed on Google and read the whole paper and understand what they have tried to do. So we end our lecture here, and hope everyone has understood the points. If you have anything further to discuss, um, do reach out for further discussions on these points. Um, Try to read the paper, read these principles again, think of your patient, and see how can you implement these things in your practice. uh, you might have seen a patient in your, or you might have presented a case. Think about whether you followed these principles or not, uh, or if you would have followed these principles, what difference these principles would have made in your care, right? Now, these principles, as I said before, applies to non-traumatic uh, musculoskeletal pain and disorders. Trauma is dealt differently. The principles change um, remarkably, right? The principles are very different for them. So this is it for today. Hope to see you in the next class.